Thank you, Mark, and a special thank you to Joe Zorc for agreeing to share the podium today. After getting talked into doing this presentation by Tony Liberti, I had many months of trepidation until Joe agreed to join me. I didn't really have the courage to carry on, but I want to talk a little bit today using examples from our experiences with Epicare and Epic Data to raise some discussion points around the idea, concept of data governance and data stewardship. So we'll walk through some examples and really raise discussion points more than provide a roadmap to the future, as it were. I'm not going to make a pitch for electronic medical records or electronic health records, but obviously there's great value in making the financial and human resource investment in implementing electronic health record, and those include better operational processes, the accessibility of the patient chart wherever they are, and patient-centered charts which pull together data from different clinical practices. These are all great. In my mind, though, ultimately, the greatest value in having an electronic health record lies in the potential to create new knowledge and thus new practice, and to provide better care and better outcomes. To fulfill that potential, though, our data requires some nurturing. Okay. Oh, good. Okay. Sorry about that. So today, basically, we want to walk through some data war stories from primary care, from the emergency department perspective, describe some of the elements that really are key to data governance, and have some discussion with questions at the end. The obligatory cartoon to start off. In case you can't read this down at Wanamaker, the caption says we have lots of information technology, we just don't have any information. I'm still surprised when I attend meetings outside of my immediate area to hear people say, oh, we can't get this data, or we can't get that report, or they say we can't derive this information from Epic. I think there's a rumor persists in spite of evidence that I hope to share today to the contrary. Sorry about that. Here we go. So I like to today set this discussion in the context of data as having a life cycle. And data just doesn't live in a vacuum, but actually begins down here at the point of care, where it's collected, and then becomes data that can be used for a variety of purposes, including quality metrics, reporting to public health agencies, supporting research through patient recruitment or identifying patients for research, and so on, through a whole cycle that actually then brings the data back around to informing what happens at the point of care and how you actually collect that data. There are sort of management issues around the data at each of those steps in the cycle, and each of those need to be considered. So in primary care, which is where my experience was for the first 8 years or so of my life here at CHOP, asthma is a ongoing condition of interest. Long time ago, before the EHR, it was really hard for us to identify, to count, and to manage a population with a specific diagnosis. In fact, it's pretty hard to do many of the things that we now take for granted when we're using Epicare. Just to put that in perspective a little bit, I can't begin to tell you how many I thought maybe I would do this, but and count them up, but we have, let's say, lots of reports that are based on the diagnosis of asthma. I thought it would be interesting to go and count them, but then thought I'd spare that tedious information. Anyway, so before Epicare, it was really hard to do these, to manage our asthma patients. And in 2001, along came Epicare, and suddenly we had the opportunity to collect data, a lot of data, in a coded method. One of those coded ways is using the ICD-9 dictionary. So these are the ICD-9 codes for dictionary. ICD-9 codes. I should say the pre-IMO ICD-9 codes for EPIC. But these codes don't make complete clinical sense, at least for the primary care setting, and at least for the physicians. And these codes describe the presentation of a condition at the point in time of care. And even given that limitation, some would argue that they're still too limited. The Joint Commission requires us to have a ambulatory summary sheet of care for each patient. In Epicare, that need is met by the snapshot, and on the snapshot you may all know that there is a problem list. The problem list is data that's something that is data related to conditions that are chronic for patients. It's not really a list of diagnoses per visit, but it's a list of chronic conditions. So the chronic conditions we like to describe in asthma are these four, which were not available in the ICD-9 dictionary at the time of go live in 2001 in primary care. So we had a problem. How do we define our asthma patients according to the National Heart, Lung, and Blood Institute guidelines and make it clinically relevant for the clinicians, and then to be able to do reporting on those severity levels that are clinically relevant? Well, the solution was back in 2001 to create our own ICD-9 codes for asthma to describe those chronic presentations of the condition. We homemade essentially some rows of data in the data dictionary in EPIC and created our own ICD-9 codes that had that prefix of 100 before the other 5 digits. For those of you who aren't familiar with the ICD-9 dictionary, it's basically currently in the ICD-9 format is a 3.2 code that accompanies each diagnosis. We added the 100 in the front of that so that we could identify our specific severity levels in asthma. So this solution worked fairly well for primary care, I think. We used it for many years, although perhaps it worked a little imperfectly. It did the job of being able to manage those patients with different severity levels. And an interesting tangential issue on this, and maybe this would be more interesting for discussion, but one of the things that began to happen after primary care went live, then other specialties came live. Those ICD-9 codes began to disappear from the problem lists, and we were finding that other clinicians looking at those problem lists said, well, this doesn't make any sense, and got rid of that one and put a new one. So a tangential issue of how do you manage the problem list, and one I think that is important relative to the discussion of data governance, because if a description is not meeting everyone's needs, or people aren't understanding what the different needs are, that needs to be addressed. But then along comes IMO, and the good news is that IMO provides us with the, boy, that sort of takes a nap between each slide, okay. Gives us the diagnosis code, or the descriptions that we want, the severity levels that are clinically relevant. But as you'll notice in the ICD-9 column here, column A, there's also, with the same ICD-9 code, 493.90, unspecified asthma. So remember I said we had a whole bunch of asthma reports? Well, all those asthma reports were based on that homemade ICD-9 code of 100, 493 point whatever. On top of that, and this is not supposed to be looking at the detail here, there's actually 90 different descriptions for asthma that are associated with that one ICD-9 code. That created a bit of a problem when IMO came into place, because we then had to adjust how we're reporting. So it raises some questions. Is it really a good practice to be adding diagnosis codes to a dictionary that's within the system? And who gives you permission to do that, or declines or denies your permission to do that? What's the body that oversees that? Is it clinical? Is it technical? Administrative? And then how does this impact reporting across the spectrum? I think it's important to note that some of us may be familiar with what happened when this change came about using the expanded ICD-9 dictionary, but not everyone within the community may have been aware of this change and may have been looking for those old codes or have been mixing up different descriptions because the codes are now the same. We're glad to know we've sorted that out. It's not an issue that's still with us, but it is important to note that familiarity with the data will help you solve the reporting problems. So let me walk through another example. Some time ago, we were asked to come up with data on birth hospitals from this template. Okay, all right. This is a newborn triage intake note that the primary care triage nurses would complete for newborns that were coming in for care. Basically, they'd reach out to the family and collect some hospital data or birth data for each patient. You can see all the sort of usual things that you see in here: the gestational age, any conditions that were related to it, and then somewhere here you see birth hospital as a line of data. We did some very rudimentary sort of text mining to come up with a count of birth hospitals, and this worked out fairly nicely. So for this example, I just direct your attention to the top row and not all the individual rows of data, but this was from, I think, a 6-month time period, and these are counts of hospitals by the primary care centers, the 4 primary care centers in the city. The urban teaching practices known now as Care Network, Cobb's Creek, and so on. And you look at the data, there's a range of numbers up there for sure, but they're sort of within the right range and could be easily explained as to why South Philadelphia might have fewer than University City or Market Street. And the distribution of the missing hospital is about the same too. That looked pretty good, and for the needs that we were asked to come up with that data, I think it met. It was specific enough or accurate enough. And then about a year later, I was asked to do the same data, and I talked about that a little bit. That all of a sudden the missing values almost disappeared. But again, looking at the top here, now we have a range of 6 birth hospitals to about 800 birth hospitals. Clearly something's going on here. The range has changed significantly. I've got a whole bunch of zeros on the right side at University City. What have they done? Well, it turns out that somewhere along the line, it was decided at some sites that rather than do the triage note, they were going to fill out this birth history section in Epicare. So the data is no longer in the note for some of the practices, and it still is in the note for other practices. It raises some interesting questions, not just about the data itself, but about practice. And one of the questions, and I know there's some primary care physicians here who might talk about this later, but how do you know where this data is if you're an Epic user? If I come to open a chart, do I have to know whether the patient was seen at one site versus another to know where to find the birth history? It's a data governance question, I think. Where should that be? Who decides where it should be? Is that something that's decided by each individual practice, each different specialty? Is it something that needs to be decided on the technical side, at clinical leadership at the ECMS level? Where does that decision belong? And then, furthermore, how does a reporting resource know where to look for this data if they would be asked? Because I think for many practices, if some report analysts went in to find the data, they just, even if they were looking for the notes, just may not find it and may not understand why it is they can't find it. So my other comment about this is you may or may not be surprised to know just how many different ways, not including typos, you can represent the hospital of the University of Pennsylvania, which is why our missing hospitals went down here. I think I finally figured out all the different ways to capture that, that value, and that's all rolled up to HOP. But you can have Hospital of the University of Pennsylvania for the person who really likes to type. You can have HOSP at Univ Penn, HOSP UPA, and just so on down the line. There's probably about 20 or 30 values represented in that line HOP. Another data governance or stewardship issue in my mind is in cases where there's free text data, how do you represent, or how do you encourage people to represent that in a consistent way? One more example from the problem list, and this is fairly brief. Again, another problem was added to our dictionary. This one, though, actually didn't have an ICD-9 code in it. It was a value which allowed practices to identify a patient as having a chronic medical condition regardless of what that condition was. And basically, these are patients that would get an extra attention, as it were, for case management, follow-up for different tests or follow-up exams or referrals and so on. Again, worked fairly well until this column was added to the schedule view for some of the sites. Just primary care? That gets that?
It's per practice.
Okay, so some of the sites. So if you've not seen this column in your schedule, don't be surprised. But this appears for the PERC sites, and it's a little bit of extra data. There's a group of primary care sites that are involved in a chronic care initiative who were using that chronic medical condition diagnosis, and then realized that if they could get this value in the column, this chronic medical condition value, or in this column, that would help the clinicians, the nurses, and the physicians to better organize their day and be prepared for who was coming in. The problem was that the ICD-9 code or the diagnosis that was created 5 or 6 years ago, not having an ICD-9 code, prevented it from appearing in this column. So now they have to go back and change all those so that they get a valid ICD-9 code to work in this column. So a decision made some time ago, maybe somewhat unpredictable what the future would bring, but sort of going off the farm a little bit there, prevented that functionality from appearing for Epic users. And here's my sort of grab bag of questions. You'd be surprised to know, you'd be surprised how much discussion, questions around what is a well visit can bring, particularly once you get outside of, for example, the primary care network. Or even, what is an office visit? And what is an office visit depending on what is your question? Back in 2007, when PARC went live, somewhat predictably, there were all of a sudden different counts of how many visits there were in particular primary care practices. And this has to do with whether you're counting based on a compliance issue or a billing issue, and what's something that generates revenue versus what is actually activity. Because in the primary care network, there may be many office visits where there's actually no billable activity. It means that there's not revenue associated with it, but it does mean that there is a human resource need for that visit. But how do you define what is a well visit? And then another question comes up of how do you identify patients with certain conditions? There's always an ICD-9 code or a problemless value. There are encounter values for diagnoses. But there are also test results. There are also medications. How do you best define a patient with, for example, ADHD? Do you assume that the problem list is always correct and that that's how you would count them? Or do you need to look at something else like the presence of a medication for that condition? So I use some very narrow examples, and you may be wondering, well, that's all great, it's wonderful, but they're sort of limited. However, this is a simplified view of the Epicare clinical data model. This is simplified, and it's only two-dimensional, and I think it's actually from the 2002 or 2003 model, so it's somewhat aged. Behind this, there are more tables, and there are more relationships. The data is complex, has great potential, but also there's some risk if it's not understood properly. If you think about some of the examples that I've shared and magnify those across our organization, looking at a data structure like this, I think it becomes clear that the questions become broader. So if you still think we don't have a lot of data, then the y-axis is kilobytes. In the May 2001 data dictionary, okay, not the whole data structure from which we're basing our reports, but the data dictionary from 2001 had 585 kilobytes. The current data dictionary is now up to 12,323 kilobytes of data. That's just a dictionary. At present, according to our reporting group down at Wanamaker, we have in our EPIC reporting database a little over 1.5 terabytes of data. So those little issues can get magnified when you look at the scale and the scope of the data that we have. Okay. So I like to think of data governance as providing a guardrails, if you will, around our reporting of data, as well as the collecting of data, the analysis, and then how that creates new knowledge or new processes back in the practice. It's a process that should facilitate the use of data so that it's clinically appropriate at the point of care, but then also understandable through that life cycle. Provides a structure for sharing knowledge about data that we have and trying to bring some consistency to practice around how you count one thing or another, how you describe one thing or another. And importantly, how you communicate that across the network so that we're beginning to speak a language that is somewhat consistent and that when 3 different people ask me the same question, they're getting the same answer and not something that requires some interpretation. Oop. Okay, there's a couple slides missing there, but Dave, why don't I turn it over to you, Joe? And we can, no, go ahead.
All right, so I think Jonathan asked me to help out with this just to help get a little discussion going around this, because I'm sure there are many folks in this audience who have more expertise in this area than myself. But also just to share a little bit from the clinician perspective, when you're talking about data governance, the key issue is how does the data get there in the first place, and in a clinical system, how do clinicians behave? So being a medical school professor and all that, I thought it'd probably be best to do a thorough, academic evidence-based review of the literature on what is data governance. This is Jonathan's, yeah. This is not mine. Jonathan probably did that, actually. But, and stewardship, we could talk about these things in a moment. But so in here, and I think it's impressive when Wikipedia says, data governance is an emerging discipline with an evolving definitions. Essentially, nobody knows what that is, really. But I thought actually some interesting points made in here. It's a set of processes that ensures that important data assets are formally managed throughout an enterprise. Data governance ensures that data can be trusted and that people can be made accountable for any adverse event that happens because of low data quality. And anybody working in an academic medical center, that's not really sounding like an academic medical center, which people say are the most complex institutions created in human civilization. There's so many different folks answering to different leaders, and it's very difficult to hold people accountable for entering data incorrectly into a system. So what about looking in the actual medical literature? There's not a great deal about data governance. This is an article from Jamia, kind of one of the white paper type articles that that organization does, talking mostly about personal health records where data governance, where people are inputting their own personal data, and data governance is certainly an important issue, mostly the stewardship part of it, so making sure that it doesn't fall into the wrong hands. But emphasizing that data must be of a minimum quality, accurate, reproducible, complete, timely, and credible. And I think probably a key thing, data limitations should be acknowledged and described. I think it's going to be difficult in an academic medical center environment to make sure that data is, entered always thoroughly and completely, but you want to know what the limitations are. And often when people ask me for reports from the emergency department, I think that's a good part of it, is knowing how the data is gathered in the first place and what are the limitations and strengths of it. And this is an article also from Jamia looking at what are leading healthcare institutions, what kind of structures have they set up for governance for their personal health records, and really finding that there were a lot of varieties of what these organizations, and these are large, large healthcare systems and things like that, have done to set up governance structures. There isn't really any standard on this right now, which I think is, there's pluses and minuses on that. You have to develop your own experience, I think, in each institution probably. There's not a place you can go to say how this is done successfully, that I know of at least. So I thought a little bit about what are the data governance structures at CHOP that you could use as sort of a model for this type of a thing. And I think they probably, and it's probably not in other areas also, but to me there's on the IS side, the Change Control Committee, which I've never been to, but I've heard about. And it seems like a very formal governance structure in terms of a place where you go wanting to make a change in a system. And my sense of it is that there's a lot of attention paid to how that might impact the performance of the system, generate help desk calls, things like that. And that there's a great deal of scrutiny attention paid to those issues with changes in the system. The clinical data and the drop-down lists and things like that, I think probably not so much. And my sense is that, at least from having passed things through there, is that they assume that the clinician's doing that, well, they know what they're doing, and they're going to have the appropriate content there, which I think is probably not the case in a lot of situations. And we can look at some examples of that. Then on the other large organization, part of the organization that really has a stake in this is health information management, so medical records. And I think an example there of a real governance structure is the Forms Committee, which if anyone has been through the Forms Committee here at CHOP, is I think a model of a very structured governance committee. And basically you bring your form there, and there's a group of folks with a wide range of expertise from medicine, nursing, legal, risk management, quality and safety, and it's extremely detailed scrutiny of the form, and how's it laid out, what are the abbreviations in there, and as a result, I think we have excellent forms at CHOP for the most part, but it's a very, detailed and thorough process, and I can't imagine, I think medical records this is clearly data entry and data governance is an issue for them, especially pertaining to clinical data. But I can't imagine going through every piece of smart text or every drop-down list in that kind of a fashion. So, even with the medical record, the Forms Committee will create a page, and up there is a reminder not to use these dangerous abbreviations. But of course, with traditional medical records, the vast majority of content is really free-form, unstructured, and there's really no way for medical records to ensure that you have quality data in there. And that's the reality of the medical record. It's if you were to transform this into discrete data, there's a lot of potential issues with quality and accuracy. When you get to medical records, so here's a smart text I created in Epic. So I violated about 6 of those rules about dangerous abbreviations, which is kind of a simple example, but I can create this and then I can use it repeatedly again and again, and I can share it with my colleagues. So essentially, something that's become an informal, unstructured note can become a structured, essentially like a piece of structured form. So I think there are a lot of issues with that in terms of how medical records would try to write herd on that and make sure that we use good quality information gets into the system. So what about, so those are probably examples of data governance structures. What are collaborations between clinicians and IS at CHOP and ways where you could develop better ways to record data and make sure that the data that we're trying to govern starts out in good shape. So first you have the IS clinical group systems, so CHOP-Link, all of the folks that have been working on the EPIC build right now have spent a lot of time trying to ensure that the data is of high quality. You have some formal collaborations between the medical staff and IS, one committee being the ECMS-IS committee, so it's a committee of the medical staff where just really set up to help information systems do their job and give clinical input in a structured way and feedback. And we have a committee there that's been working for the past 10 years on clinical decision support, so really focusing on the alerts that the systems present to clinicians in particular and the decision support regarding dosing, especially pharmacy type things. And I think that's been a nice example of a collaboration between IS and medical staff to come up with a lot of kind of best practices and sort of routines that when new situations come up, we say, well, we've dealt with a system like that in the past, or an issue or concern, and here's a principle relating to alerts or other decision support for clinicians that serve us well. And then recently we started another subcommittee regarding reporting and data quality, which is really focusing on the output from the clinical systems, particularly the folks like myself that often have to produce reports from the clinical data. And as soon as you start doing that, you run into questions of quality and understanding what the data is and what are the limitations of it. And then you have the Center for Biomedical Informatics, which is focused more on the research side of data and using it for research purposes. So I think these are all examples of ways to bring together the IS side and clinicians to develop best practices and share knowledge so that even without a formal structured governance structure, you may be able to know the strengths and limitations of data and make sure that the way data is captured in the future is as good as possible. So I just want to run through some examples from our emergency build for the emergency department for EPIC that's going live in January for some of the experiences we've had there. And just things that I've noticed in the system. So here's a pop-up that a clinician would get. This is what you get. I think it's currently live in the current system, but it's definitely in the acute dev system right now. So this is what you get if you're discontinuing a medication, really for any reason. And so it could be something as straightforward as therapy completed, like they're better, or important pieces of information like they had an allergy to it or a side effect. And so side effects of medications are really supposed to be collected and reported back to the FDA so they can, decide whether medications are safe. So those are important, goals of that information. Lots of different things here. And I think probably as a clinician working in the ED, my eye always gravitates towards the other. And this one actually doesn't even, I don't think it gives you a text box to put in a choice comment, which the folks on the CDS committee from our other alerts, we have there's a long list of comments that people have put in on the other slot for a medication alert. So I think you could assume that a clinician, when presented with this, are they going to really spend the time to go through this list and pick out the answer that you want them to? Probably we need some type of guidelines and best practices about what are the limits of numbers of choices that you can have on a drop-down list if you're going to expect clinicians to read those and make a decision about it. I think that would be a best practice to think about as an institution. And we can talk about different situations because it's not always going to be the same. It would depend upon how familiar the user is with the topic and how they're organized. So these are really just arbitrarily written things that are in alphabetical order. So there's not really any sense of, the most common one would be therapy completed, he's better, I'm done with treating him with this medication. It's the last one on the list, for example, and was that the best way to arrange this list? On the other hand, on the other extreme, this is the alert that you get in the Epic system as currently built for acute when you want to override an alert. So here I'm giving a massive overdose of Tylenol to someone, and I get three. I have to say, the first time I saw this, I loved it as a clinician. But you get three options. So benefit outweighs risk. So because I said so, basically, I'm taking the responsibility for that. Then there's current therapy, which is he's already on this medication. Somebody else decided, I guess, that this is the appropriate dose for them, so I'm not responsible for it, but it's on somebody else. And then there's not applicable. I'm not sure what that means, but it would be interesting to see the responses that we get from this alert over time. And while this is very appealing to the clinician in me, is this really what we need to improve the system over time? Because our experience with the Clinical Decision Support Committee and alerts is that often the alerts are wrong. That's the problem with them. It's fired inaccurately. In this case, it was accurate. But how are we going to get that feedback back so that we can fix the alerts if we wanted to? So you want to collect enough information to get that kind of information so you can improve the system over time. So I would argue this list needs to be a little longer probably so we can capture more information about what's going on when a clinician is deciding to override a decision support alert. So just from my experience with this, put together a few kind of ideas for best practices for designing clinician data entry. And just with any data exercise in research or clinical care, the first thing we want to do is consider the goal of data collection. What are we going to do with this data eventually, and what's the real purpose? So for the first one, if I showed, if it's really to gather adverse events from medications and report them to the FDA, which I imagine it probably is, well then maybe we should design the form in that way so that it's clear. There are other goals, and you don't want to design these types of drop-downs by committee with people sitting around the table saying, oh, that's another possibility, and this and that. That's where you end up with these lengthy lists. How will the unexpected responses be counted for? So you always want to have another, and then you want to design a system so that you can use that information. And then you have to consider the trade-off between usability and completeness. So 3 things on a list is very usable, but may not be complete enough to be useful for your purposes. And then understanding your users is obviously a key part of designing any type of system that clinicians are going to interact with. So we can go through our example from the emergency department. So this is so our system in the ED is WellSoft. We've had that for almost exactly 10 years now. And the way the diagnoses work in there is that there's a wide open list essentially taken from the ICD-9 code book. And they've done a nice job actually of tailoring it a little bit so that it's in clinician speak and changing the titles. So if you look in ICD-9 world, it's like injury due to, and it's a list of 10,000 things. So if you type in injury, you get this long list of things. But unless you change the names of the codes, you won't be able to really use that sensibly as a clinician. So we've had a lot of fun in the ED exploring that list over the past 10 years. One of our most popular is Found Dead on Railroad. Fortunately, we don't get a lot of those in the CHOP ED, and they don't tend to do that well. But that's an example of an E code, which is an injury code, which can't be a primary diagnosis for a visit, but it's an important secondary diagnosis, particularly if you want to do something about injuries, move the railroad tracks or whatever, put up a crossing guard or something like that. So looking at our typical diagnosis information, this is essentially a natural experiment. We've given clinicians this massive list of diagnoses for the past 10 years, let them go to town with it, and so I use this as a source of data to design our Epic build. And in a typical year, we have 85,000 visits last year with only 3,500 primary diagnoses used. And interestingly, of those 3,500, only 40 of them account for 90% of the visits. So if you run out a histogram, this actually would continue to go out for like, that 5 feet in that direction. There's a ton of, titles of diagnoses that people have picked a couple times, during the year. And then a large number that are picked very frequently. So it doesn't really conform to the typical 80-20, 90-10 kind of rule of things that you would expect in any system that, the large majority of things would be by a small amount, but you have this huge tail of things that are used probably, in an inconsistent way by people. So now you get to Epic, and Epic, as Jonathan was talking about, has the intelligent medical objects. We have it supplemented with that, which basically takes the ICD-9 code and just, expends it out exponentially with all types of specially tailored codes. So when you type in, so one of the most common reasons come to the nurse department is an injury. One of those common injuries is due to a fall. That's the most common injury mechanism. You type in fall, and you can get pretty quickly overwhelmed by all the, these are all the E-codes, and then their supplemented E-codes. So one of my favorites is fall from Heelys, spelled two different ways, which is basically that they're taking the code from fall from roller skates and then building it out. And you can see if you were trying to use this data, somewhere there's a field in Epic where it records this extra digit. And if you really wanted to use that information in detail, you just have to spend a lot of time going through the diagnosis catalog to figure out. I think this is a great thing, actually, because what have they done? They've thought about and probably based on something, what are the clinicians going to type in? So if the clinician wanted to type Heelys and record that information, well, they know that they'd probably misspell it in different ways, so they put both options in to capture that. So I think it's a very good thing in a way. By the way, it's Y, Heelys. These are little shoes with the wheels in the heels, if people don't know what it is. So it's there for you, but is anyone going to use that really? I would question it, at least for the most part. But it is a relevant thing. I've on several occasions, been asked by the press and other sources how many injuries from Heelys that we had on CHOP ED, and any kind of new product comes out, we'll often get requests from numerous sources about that. Fortunately, we're not. There are people who do that for a living. We actually have folks in our ED looking at all the records, filing reports to the Consumer Product Safety Commission about things like that. So that's not really our job, but how much granular data should we really collect on something like that? So what we did is took all of those E-codes, and we actually were able to benchmark it with some of the other children's hospitals that are in our research network. We shared data together. So we looked at what are the codes that account for, it's really more than 90% of the injury codes that we have, and look also at the other children's hospitals to make sure that it was consistent with them. So we boiled it down to a list of about 20. And we can talk about the pros and cons of doing this, but I think this will at least be usable for the users. So for most of the majority of sort of mundane injury types that we see, we have a short list of diagnoses that I think people will get to know fairly quickly and become fairly familiar with. How to order this and how to set it up for clinicians, that's a wide open topic. I tried to make it in order of frequency for the most part. So understanding your users in the ED, our users, the weak link of the ED in terms of users are rotating residents. So we have residents that come through the ED, we have several hundred per year, and they're expected to come right on board with the system and start using it within hours, and they're the ones that type in the diagnoses. They have a very steep learning curve, so they're only here for 3 or 4 weeks, and by the end of that time period, they're gone. So they really don't have time to get used to the system and very comfortable with all the ins and outs of it. So how do we tailor that to them? And this might seem to violate my principle of being too long of a list, but this is the list that our triage nurses use at a triage when they're seeing a patient and trying to categorize them into different groups. And so we have a list of about 50 triage diagnoses, essentially, that the nurse would use to categorize patients. And this would seem to be, overwhelming, but it's actually the way that our nurses think when they're trained to triage, and we have a very structured triage manual that's been developed at CHOP over decades, probably, that really spells out what are the criteria that you would use as a nurse at triage for each type of complaint to categorize them. And this is a fairly unique and useful resource that most children's hospitals don't have. So the nurses think about it in this way, and they immediately, when they see a patient, will know where to categorize them. They need to know to go where in the book would they go to figure out how to categorize that patient. So they can immediately place them in one of those 50 bins. And we look at how that breaks our visits out when we take our triage diagnoses, the current impression is what it's called. You can see the frequency, the most common being respiratory distress, some of the trauma triage complaints. But very quickly you get well over 90% of our visits are covered in those 50 discrete buckets. So when the nurse triages the patient, we can use that to build upon and kind of comb down all the world of possible diagnoses and problems for the physician staff who are going to be less familiar users of the system. And here's if the nurse has selected abdominal pain, the options that they'll get in terms of order sets and discharge sets, which include diagnoses. So if you pick constipation here, and in order to do this, we ran frequencies on all the patients that came in with a triage complaint of abdominal pain, and then looked at what were the different diagnoses they had and what were the medications that were assigned, and how could we further divide them into bins. So if you pick constipation, then you can get down to these are the top 5 diagnoses that we used for those patients, and really down to the level of diagnoses that were used at every month level, so for pretty infrequently, as well as medications that go along with that. So really guiding the clinician to the kind of smaller universe of diagnosis codes that they might frequently use for those types of patients. So how can we simplify data, I think is a big important thing. If you want to have data that you can govern, how can you design it for clinicians so it's simplified and they can get their hands around it? I think most clinicians would like to give you the data that you want and make sure that it's correct, but you have to give them a structure and a simplification to do that. How will this be improved over time? So this is the mechanism of injury codes that I talked about. This is what you would get if you were discharging a patient with a head trauma. So these are the most common diagnoses that we use for those patients, and then the mechanism of injury codes afterwards. Is this the ideal way to do this? I'm not really sure. We're giving up a lot of specificity by coning it down to 20 common injury codes. What would I think be much more ideal would be several of the fall from most common things. We chose playground equipment because we know there's a research study going on about playground equipment in West Philadelphia, so we wanted to capture that. Probably would make more sense would be fall from some of the boring things and then fall from an interesting mechanism. And you click on that, and then you would get an option of the Healy's and all sorts of things that you might want to capture more granular data on. And that would probably be the ideal way to do this as we evolve the system over time. But this is what we thought would be most functional for folks as we go live with the new system in ED in 2011. So Jonathan and I spent some time talking about examples of past problems with data governance and some approaches to improvement. How to do data governance at CHOP, I don't think we have any answers there. Should there be a CHOP data governance board? How should that interact with existing oversight structures in HIM and IS, the HIM committees and information system committees like change control? I think at some level you have to have some structure in each of those areas. So an IS committee looking really at those definitions of visits and things like that so that they're structured in a very clear way with the level of detail that is given to the performance issues for the systems. And on the HIM side, some level, I think, of review of the drop-down lists and smart text that's created so that it fits the regulatory needs and makes sense and is sort of consistent across all the different areas that work in a hospital. But probably the most important thing, I think, would be to develop best practices so that we can try to collect the data in an effective way so that the governance issues would be minimized because you understand how the data is created and are able to understand its limitations and strengths. So with that, we'd be happy to take any comments or discussion ideas if anybody has any experience of this from other institutions or thoughts. Anyone? Oh, good. Ross Capel. Always has something to say. Hello, Patty.
Thank you. Both presentations were wonderful. I appreciate them. In the list of Healy's that you had, the bottom line read roller skate or roller shoes error. And it occurred to me that you had the severe problem of not mutually exclusive or collectively exhaustive writ large. It was a fall, and because the word roller started later than Healy, they were separated. But I mean, if I were in the ED and wanting to code the problem, I might say roller skates, and I see roller shoes, and I don't know what a Healy is, but I assume it's something like that.
Right.
So you have that non-mutually exclusive problem, and that happened a lot. I mean, you had sprain hyperextension, and the next one was, it was hit by somebody. Well, you could be hit and hyperextend on the way down. that was pandemic throughout all of these lists. The other point was in the list of reasons why you were overriding, you had not appropriate, previous physician ordered it, and one other thing I can't remember.
Yeah, there's a lot of mutually exclusive things in that list, for sure.
There was no line saying, this alert is idiotic and doesn't belong. And yet, that's what you said you were looking for.
Right.
So, very often, we don't ask the question, yeah, pass it.
Yeah.
We don't ask the question that we really want. And I saw that repeatedly as something that could happen. Thank you.
Sure. Dean, go for it. I think, Dean, would you like to run for data governor?
No, thank you. No, I was interested, and no surprise, in the continual reference to the relationship between the design on the front end and the resulting data in the back end and structure. And I think that's something we can look at a lot more closely. But also, with these lists, I've been thinking about this for a while. These are essentially search problems that there's plenty of research and methods and technology we use every day that has addressed a lot of these issues for decades, yet the EMR seems really primitive in applying the same techniques. The SORI, the whole issue, we understand the basic problem is people use different terms to describe the same thing, and this concept's been around for some time. So I feel we're very limited by the EMR design in addressing a lot of these issues. We can do a lot to design our lists and be more careful, but I think we need more help from the vendor, a little more sophistication in technologies we see from everything from Google to iTunes right now that aren't in our very expensive unit.
Absolutely, yeah. I mean, what I've always pressed is that it tries to take care of it in one shot. So it gives you a list, and then you have to search through, as opposed to more of a delving into getting deeper levels of search. So you should be able to, I think actually the Epic search capability is reasonably good, especially the diagnosis list part of it. And it varies throughout the system too, which is an interesting thing. In some areas you can search by embedded terms within a larger term. In other areas you can't. And it's always a little bewildering when you're a user to figure out, oh, I can't do that now. I have to know exactly what it is. And kind of, especially in the more park kind of registration functionality, it seems like it's like a deeper, more primitive layer of Epic where you have to have the full, address of the user to send them an inbox message or something like that. It doesn't search for the embedded matches. And I would hope that they're going to improve that over time.
And one other thing, I think you're missing one from that list. Insurance no longer covers.
Right.
Oh, you got it.
Not approved by insurance company, of course, right here.
I was joking.
But this really should be, I would think, as you point out, like the search strategy here would be, there should be 3 or 4 categories, and if you're doing this as a survey, you would have 3 or 4 categories of like, we're done with this treatment, or there was a problem, and then you would go into another level of like, well, what type of problem did he have? Was it an allergic reaction? Was it some other type of adverse event? Because I don't think you would get that information here. You might sort of get a flag that there was an issue, but it tries to do it all in one, which puts a lot of burden on the clinician.
Wanted to add one more point, which is any list, but especially an order set, is a closet CDS order. And for instance, when you showed the systematized creation at the end of the presentation where you had most common diagnoses and most common medication, well, we can bet your bottom dollar that those 5 medications are going to be the ones that are picked. And
right.
They might not be the most appropriate for all of those problems.
Absolutely. And the way I avoided that myself is by doing it in a totally data-driven way. So again, our current system gives no decision support whatsoever. Clinicians are just free to enter what they want, of course within the list of things that are there, but it's pretty complete. So I saw what did people actually order and put that on the list as opposed to trying to steer them to that. So at least people say, well, that's not on the list, or why are you putting this on here? Because there's no doubt that by putting something on the list, it will increase its stock and market value in our CHOP system greatly. But it's based on what people actually did in the free-form environment. So I felt a little bit better about that because it's data-driven.
It seems that external factors often influence how well or how consistently we govern our data for ICD-9 billing diagnoses. We're responding to payers. And HIM, it seems, represents a bunch of different concerns in how they govern forms. Outside of those two, what are other external factors you see influencing how we govern our data now? And you know, what would be some that you see coming down the road?
Well, I think payers is a huge one, and I think that's often the source of a lot of the, and Jonathan could probably comment on this better, but a lot of the complexities. I know for an ED patient, their identity in the systems can change depending on essentially payer-driven things. So they might start as an ED patient, change into an admission, change back into an observation, all based on what is the optimal way to submit it to a payer. So that could be very confusing if you're trying to use the data because, well, wait a minute, it can actually change too over time. You can see a patient's, what happened to them in the hospital change based on sort of payer-driven aspects. Regulatory issues, certainly Jonathan was showing asthma. I know the Joint Commission at one point required CHOP to report asthma metrics and make them publicly available, so all of a sudden a lot more attention was paid on that weight data, asthma data was gathered, and I feel relatively good about that now. But it's very erratic and driven by whatever the issue of the day is, so it'd be better to take a more comprehensive look at that.
So it seems like perhaps the extent to which you can get good quality data captured is based upon how much we can incentivize the disparate individuals across an institution and externally that are entering that data. So do you have thoughts about how you might do that?
I think it's all about making, from my experience in the ED, it's all about making your job easier. So if you can create systems that are easier for people to do that way, and that's why I hope we'll see, it'll be interesting to see how our approach with smart sets and all of that in the ED, that's a new concept for us. But I'm hoping that people will immediately see, like, wait, there's fewer clicks if I go through the smart set and use the recommended things as opposed to doing it all through text on my own. So I think that's the key thing. It's really paying extreme attention to what's the workflow for clinicians and making it so that the path of least resistance is to do it in a way that's easy to do, and it gives you good data. And then when you have to walk people through more complex flows, just really, I think you can pretty quickly, and all of us do this enough on a daily basis, you can pretty quickly tell when has a lot of attention been paid to this, and when is it just a list of things that's thrown at me and it's really not been thought through very carefully. And making it obvious that, like, oh, somebody's thought about this and given the time, and someone's probably using this data, then I think people are responding much more positively. I hear Jonathan too.
No, I agree. I couldn't add too much to that. I just wondered if there are any questions from Wanamaker. Or are you still there?
Hi, John, and I'm here.
Okay.
So a question, conceding that it is after 1, I
Sure.
just wanted to say thank you so much to both Jonathan and to Joe for presenting a wonderful presentation, very thought-provoking, and I'm sure that they'll be up here if you guys have any other questions to come up.